And right from top left that we are recording this. That is because we have many members and people from outside of Nashville who would like to see this content and are not available to attend the Zoom in person. So this Zoom will be available on the Breast Cancer Recovery and Action website in a week or two. And we'll be very happy for you to come back and reference it for your own interest. And we look forward to everybody who watches this at a later date and time. We are a Nashville-based nonprofit that provides programs for women in the breast cancer community. They involve nutrition, fitness, small group discussion, and educational programs. And we invite you to learn more about us if you're already not a member of BRA groups. As a matter of housekeeping, we would appreciate it if you would keep your microphone on mute while we are having our conversation, just to avoid background noise. It makes it easier. If you would like to participate in the conversation, you can use the chat. We have a laptop open here so that we can monitor the chat. And you're also, if you're not comfortable with chat, just give a little wave and Jahan and I will keep our eye out for you. Let's see. And so I think that's all of the nuts and bolts. So with that, I'm going to turn you over to Jahan.
Hey, welcome everybody. Like Lynn said, we're so glad to have you. And I have the privilege of introducing our speaker today. And she comes to us through a committed BRA member who sees her as a patient. And so she comes highly recommended, both personally and professionally. But we're thrilled to have Amy Ervin with us. She is a cardiac nurse practitioner at Ascension St. Thomas here in Nashville. She's a wife and a mom, and she said when she's not treating people for cardiac health, she's momming. So I can relate to that. We are going to kick it off to her because she's got lots of great information and things to share with us. But as always, I love to hear kind of first of all, thank you, Amy, for being here. And I would love to hear more about your background and how you got into this field and why. I know you told me that your grandmother was a breast cancer survivor. So I'm going to kick it off to you and just let you share some about who you are and what you do.
All right. Can everybody hear me?
Yes.
Okay.
Perfect.
All right. Hey, good afternoon, everybody. I'm Amy Ervin. I am a nurse practitioner for St. Thomas Heart. I work out of the Williamson Medical Center at our Franklin location. So it's a pleasure to be with everybody today. And hopefully I'll share some insight with you that will positively impact your cardiovascular health. So I graduated nursing school in 2001. And I got married and moved to Oklahoma City, and I worked in heart and lung transplant there. And that was a really formative year of my life because I was a very, very new nurse. And I was dealing with patients who were very sick and had really a second chance at life. And one of the things I kind of took away from that experience, and I would hopefully bring into my practice every day now, is that patients really know their bodies well. And so if they're telling you that something's going on, you need to listen. And you need to find whatever solution needs to be found in order to make sure that they're getting the help that they need. So I try to be a really good listener when I'm in the clinic with my patients and make sure that we work together to bring you good health. I moved out of, I heard somebody mention Memphis. I moved from Oklahoma City and then moved to Memphis, Tennessee, and worked there on just in the hospital setting while I was getting my master's degree. And then was a cardiovascular nurse practitioner for Stern Cardiovascular Center in Germantown, Tennessee. And the physician that I worked for did a lot of heart failure and did research there. So some of the medications that are out today that are kind of standard of care were medicines that we did investigative work on at Stern Cardiovascular Center. So that particular cardiologist wanted or asked me to become an expert in advanced lipid and cholesterol testing. And so that's really where my love of prevention and cardiology kind of meshed together. And so I really do enjoy educating patients about cholesterol and kind of uncovering their risk for heart disease and making sure that we are treating you to the best of my ability. So anyway, just a second, sorry. So one of the things that I did during my kind of time of learning about advanced cholesterol testing was doing a conference with Dr. Bradley Bell and Dr. Amy Deneen. They have a method of cardiovascular prevention. And so they have 2 books that are out. One of them is called Beat the Heart Attack Gene, and the other one is Healthy Heart, Healthy Brain. So those are really good resources if you just kind of want to have a better understanding of cardiovascular disease. I ended up through that conference meeting a physician, and we ran a heart attack, stroke, and diabetes prevention clinic together in Memphis for about 2.5 years. And then that kind of fast forward, I ended up moving to Nashville. And then I've worked now for St. Thomas Heart for about 5 years. So they're just kind of thinking about certainly my grandmother is a breast cancer survivor. She ended up passing away after a bypass surgery. So I have an appreciation for just her toughness of making it through breast cancer. And then knowing that her risk factors were not well treated by her primary care doctor has kind of spurred me on to make sure that I do my very best to take care of my patients in order to reduce their risk of ever having to go through a bypass surgery, if possible. So there are some kind of thinking about that with that in mind. There's basically some key concepts that I talk about on a day-to-day basis with my patients in order to educate them about their cardiovascular risk and what we can do to mitigate that risk and reduce the risk and reduce your chance of having a heart attack or significant coronary artery disease in the future. So, all of you have already experienced a health crisis, being told that you have cancer, whether you're in the battle or whether you have completed that battle. I want to do my very best to talk about some things that hopefully will not allow you to ever have to have a heart attack or a stroke, because that is another health crisis with long-term effects. And honestly, 50 to 80% of heart attacks are preventable. If we're taking care of our risk factors for heart disease, we have a less risk of having that sudden heart attack. So I want to make sure that we discuss those risk factors today. So according to the American Heart Association, cardiovascular disease kills more women than all forms of cancer combined. And yet, when those women were polled as far as what is your greatest health risk, only less than 0.5% of women understand that their greatest health risk is a cardiovascular disease related. Another stat that just is, to me, mind-boggling. Among females that are 20 years and older, nearly 45% are already living with some cardiovascular disease. And only 50% of women who are getting pregnant at this time are considered to be in good health. So what we're seeing is that we are finding heart disease in women at a much earlier age. And when I say heart disease, that's a very generic term, but I really am just talking about plaque in the heart arteries, okay? And so we tend, in the past, women haven't been as prone to having plaque in the heart arteries until late in life, but we're finding plaque in the arteries at a much earlier age, and my female patients are having heart events at an earlier age at this time. So again, prevention is key in knowing your risk and knowing what are the best screening tools, and just even understanding your own lab work in a way, are my labs, my cholesterol levels, my blood sugar, are these things placing me at risk? Those are the things I want to make sure that we talk about today. Also, women too, we tend to have more complex heart disease. Our arteries are smaller a lot of times than our male counterparts. And so we tend to have that small vessel disease, which is more difficult to do an angioplasty or a stent. And a lot of times we have a lot of plaque that builds up in these small arteries, and that can certainly cause more symptoms and can be just a little bit more complex to treat. So the main message I want to share with you today is that the earlier that we find plaque in the heart arteries, and then the earlier we start to treat your risk factors for plaque in the arteries, the less risk you have of having a heart attack or having progression of coronary artery disease. So I have a couple of things I want to make sure we talk about. I have like 5 slides that I want to kind of share with you if I have the opportunity. Number one is just kind of what is the story of plaque? What causes plaque to form in the artery? And what causes plaque to progress in the artery, and what causes a heart attack. So plaque forming in the artery is a multifactorial, it's a multi-step disease that involves inflammation at each point during that process of plaque being formed. So inflammation in the artery wall causes plaque to form, causes plaque to grow, and what can cause plaque to become unstable or rupture. When plaque ruptures, that's what can cause a sudden heart attack or a stroke. So we want to know if there's plaque in that artery wall, and we want to look for those risk factors that would place you at a higher risk for having inflammation in the artery wall. So I'm going to see if I can share. Can I go ahead and share my screen?
I think I set it up where you can. So let's
Yeah,
try
thank
it.
you. All right, let me see if I can do this. This is all.
Technology is not my
I
strong
know.
suit, and all these ladies that come
Every-
regularly, they know that about me.
Well, I may not have, I don't know if I have it on my Google Drive. Let's see. I don't want to do that. I may not be able to do it.
Yeah,
Oh shoot, is it something on my end?
I think it's, well, let's see. Let me do it from my desktop. Okay. Let me see if it'll let me. Do you hear me?
we do.
Yeah, we do.
Okay. All right. Yeah. Okay. So let me get there. Okay. Can you see that?
No.
Can you see my screen?
No.
Okay. Because I can see what I'm looking at.
No.
Okay.
I'm just making sure.
Okay. I tell you what, I always as a let me see if I can find where you guys are again. Can you see me?
Yes, we see you.
Yes.
Okay. I'm trying to think.
Share screen. I just don't know. I'm trying to make it where other people.
Yeah, I thought you gave her
I
permission.
thought I did too.
I thought I did, yeah.
And
And that's my screen.
yeah.
That's not what I want to share.
No.
Okay, hold on. I've got another idea. Give me just
All
a
right.
second.
Oh.
I like it. Improvise on the fly.
She left us.
Did she get the memo to wear pink today?
Yeah, we did.
Yeah, we
click share
did. We
screen,
did,
yeah.
Christy. Thank you. I don't know. I clicked.
It says multiple
Advanced sharing
participants.
options, and who can share? All participants.
Yeah, she's clicked all participants,
It
multiple
looks like
participants.
it's checked on my side.
I think it's the same thing we
Sorry,
did
guys.
last year. Here we go. Perfect.
Look at her. She's got visuals. I love it.
All right, can you guys see this?
Oh, yeah. Yes.
Okay, wonderful. All right. So this is just kind of a picture of plaque forming in the heart arteries.
Mhm.
So this would be a normal artery, no plaque in that artery wall. And this little layer right here, this is kind of like an off-white color right there. That's called the endothelium. And the endothelium is the protective layer of the heart artery, okay? When that endothelium is intact, then it's very difficult for bad cholesterol to get in the artery and form plaque. And if you the arterial highway within the body all has this endothelium. And if you were to lay the endothelium out for the entire arterial system, it's about the size of the length of a tennis court. So you've got a lot of this arterial highway system. And so if I start talking about the tennis court, that's what I'm talking about, that protective layer of the heart artery. But if that protective layer of the artery starts to get beat up, then what happens is plaque starts to get into the artery wall. And then we start forming plaque in the artery wall. So that in and of itself is not a problem, but when there's inflammation in the artery wall plus plaque formation in the artery wall, that's where things can go awry. So we can start to have more and more plaque build up if there's inflammation in that artery wall plus bad cholesterol in that artery wall. And over time, we can start to have enough plaque or enough inflammation in that artery wall where we can have a plaque rupture. And when that plaque ruptures, the body sees that as injury. And you can have little plaque ruptures that don't cause, that you don't ever feel. But are creating more and more plaque and more damage to that tennis court, that protective layer of the artery. And then if we have a big plaque rupture, that's what can cause a heart attack or a stroke. And so basically a big plaque rupture means red blood cells and white blood cells start coming to that area where that plaque rupture occurred because that was injury to the body. So if those red blood cells are big enough, or if enough red blood cells clump together, then a blood clot's going to form. If that blood clot is big enough, that's what actually obstructs blood flow and causes a big heart attack or a stroke. So we want to keep the artery wall nice and cool and keep that tennis court intact. And we want to do our very best to keep bad cholesterol out of that artery wall. So the way that we do that is by making sure that we have a good understanding of your risk factors. And there are kind of 5 big risk factors that I probably talk about every day. And one of those risk factors is your genetics. So certainly if you have a family history of heart disease, then we know that you're going to be at a higher risk of plaque forming in the heart arteries. And I certainly have patients who say, okay, yeah, my grandfather, he had a heart attack at 60, but he smoked his entire life and ate sausage 3 times a day. And I don't do that. So I tend to, have more of my mom's genetics than my dad's genetics. And all that is important information for me to know, but I would just say if there is a family history, look for other risk factors and know your risk and know whether or not you have plaque in those heart arteries. And we'll talk about some screening tests that we do for that in just a minute, but definitely family history can play a big role. Also, go ahead.
Sorry. Like how far back, like how far out does family history go? Like, are we talking immediate family? Are we going cousins? Like just in general, could you give me
I think that's a great question. So I think certainly immediate family, so parents and grandparents, but I would say look at patterns too. So sometimes, I have patients who say, okay, well, maybe it was my grandfather, but he had, 4 brothers who also had heart attacks, or, every one of my first cousins, and I'm talking about myself, every one of my first cousins has blood sugar issues.
Right.
So all the females on my mother's side of the family have a blood sugar issue. So I'm going to say, okay, I need to be looking at my blood sugar and making sure that's not a player, that's not something that's going to be happening to me, and be assessing my blood sugar and making sure that we're taking care of things. So that's a great question, but I would say extended family, but also looking for those patterns too. If you've got, 4 first cousins who've had, stents or something, then I would say that's family history, and let's have a conversation about it.
Okay.
When it comes to cholesterol is one of the most interesting things, and how we can certainly treat it has changed a lot in the last 20 years since I've been doing this. Total cholesterol is an really important number for you to know, but it doesn't tell us everything. So I think, in the past, we would say, hey, if your total cholesterol number is under 200, then you're A-okay. Total cholesterol is an important number to know, but it just doesn't give me enough information to let me know your risk of heart attack or stroke. So I really look at the breakdown of good cholesterol, bad cholesterol, and triglycerides. Triglycerides have to do with the amount of fat and sugar in the blood. My goal for triglycerides is under 150, the lower the better. When I see triglycerides that are elevated, if they're over that 150 mark, I'm always thinking, is there an underlying blood sugar issue that's causing that elevated triglyceride? if you overconsume or if you consume a lot of sugary beverages, whether it's sodas, fruit juice, or alcohol, those are things that are going to always raise triglycerides. If our diets are too heavy in sugar and carbohydrates, those are things that are going to raise triglycerides. And you can make a huge impact in lowering triglycerides without even being on medicine if we change how we're eating and how much we move. But always, when I see high triglycerides, I always look for underlying blood sugar issues, whether it's pre-diabetes or type 2 diabetes. If you have type 2 diabetes, you're at a higher risk of having high triglycerides and low HDL. Your HDL, H stands for healthy or happy. That's the good cholesterol. I want as many of those good guys as I can get. I like to keep an HDL at least above 40. The higher, the better. But HDL is like a garbage man. It goes through the artery, it picks up bad cholesterol, and it gets it out of there. So I want as many of those good guys as I can get. Exercise and just a daily movement practice really impacts HDL. So if you exercise or move more, you're going to see HDL go up. If you limit high sugar foods, high carbohydrate foods in the diet, that also will help HDL rise over time. And then LDL, L stands for lousy. That's the bad cholesterol particle. That's the bad guy that can form plaque in the heart arteries. So LDL is the plaque forming cholesterol particle, but not all LDL is the same. So you have LDL particles that are big and fluffy, and they just bounce through the artery wall and keep going. And then you have the more sinister LDL or bad cholesterols, and those are the smaller and more dense LDL. The smaller and the more dense the LDL, the more likely they're going to crack that tennis court and be able to embed themselves in the artery wall and cause plaque buildup. Also, too, lipoprotein A is an inherited abnormality of the bad cholesterol. About 30% of the population has it, and this is just a simple blood test to see if you have this. But about 30% of the population has it, and it does get passed down about 50% of the time. And so this lipoprotein A particle is it looks like a bad cholesterol particle with this little tail attached to it. And that little tail makes the bad cholesterol more dangerous. It's more likely to embed itself in the artery. It's more likely to cause inflammation in the artery. So if you have lipoprotein A, and the higher the amount of the lipoprotein A you have, the higher the risk you are of having plaque in the heart arteries, and a higher risk you are of having a heart attack. So I know if I have a patient who has this lipoprotein A gene, then I know that they're a higher risk. I know I've got to make sure I'm taking care of cholesterol really well, take care of any blood sugar issues, and I need to be really keeping kind of a surveillance on those heart arteries as well. And of course, if you have lipoprotein A, then your other family members need to be checked for it as well. You only have to have it checked once. So if you have it, we'll deal with it. If you don't have it, you don't ever have to have it checked again. There are certain cholesterol medicines that we use now that can lower lipoprotein A by about 30%. And there are new medications that are on the horizon, hopefully very soon, that are going to lower lipoprotein A by about 80 to 90% and basically take this risk factor out of play. They're just not commercially available just yet. They're in phase 3 trials. So there are things that we can do that are coming, but at this time, if you have lipoprotein A, we know, hey, we've got to get the cholesterol down, and we've got to do our due diligence to make sure those heart arteries are A-okay. Also, too, I would definitely recommend that you take a baby aspirin every day if you have lipoprotein A, because that just helps keep the artery wall nice and calm and prevents more inflammation in the artery wall. Does anyone have questions about that? Yeah.
Yeah, we got one in the chat about who would run the lipoprotein A test. Is that something that a primary care provider could do?
Yeah, primary care can do a lipoprotein A for sure.
And is that usually covered by insurance?
Yeah, it can. You can do it. You can bill it under cardiovascular screening. And certainly too, if you have high cholesterol, you can put it under, you can use a diagnosis code of hyperlipidemia. And if you have, of course, if you have coronary artery disease, then you would use that as their diagnosis code.
And then we have another question in the chat. what is the coding on a lab report in order to check if we've already had this?
Yeah.
Screening? Do you know, how would we be able to identify if we're like most of us have portals?
Oh, yeah, the
Fire,
portal. Yeah.
yeah.
So it would be listed, I don't, in a portal, I mean, every portal is so different, but I mean, and it would be under lab results.
What would it be called though? Like the.
It's lipoprotein, LIPOPROTIEN, and then A, the letter A, lipoprotein A.
And what are the numbers that you're saying we would be looking for?
Mm-hmm. Yeah, so so if it's less than 75, it's negative. If it's over 75, it's positive.
Awesome.
And the reference range will tell you, because there are different ways of measuring lipoprotein A. So there will be a reference range in the lab, but typically that's lab core.
If it's negative or protein or.
Yeah.
See, I'm so glad we're recording this because this is a lot of information.
It is. I was going over today. I was like, this is a lot. This is like drinking from a hydrant. Sorry.
Stuff though. It's good stuff. How do you find, I think Dawn has a question that you may be getting ready to address, but how do you find out about the inflammation if you have it in your arteries?
Yeah, so that's a really good question. And so, I mean, there are tests that you can do, blood tests that look for inflammation in the artery wall. One of the simplest, the cheapest one is HSCRP, or high sensitivity C reactive protein, but HSCRP, pretty much every doctor knows what that is. That is a more generalized inflammation marker, but there have been studies that show, and one study in particular was called the Jupiter trial, and my office in Germantown was a part of that trial. And so those were patients who had essentially normal cholesterol panels. So they didn't have a really high cholesterol. Their cholesterol, LDL cholesterol, was at least around 100 or lower. So they didn't have, they weren't diagnosed at that time with high cholesterol, but they were checking HSCRP, which is an inflammatory marker. If those patients had an elevated HSCRP greater than 2, then they were randomized. They were either put on no medicine or they were put on rosuvastatin, which is generic Crestor. In that study, they actually stopped the study at 2.5 years versus allowing it to go out 5 years, because the patients who were on rosuvastatin, who had that high inflammation marker at the start, had less heart attacks and strokes. And the data was compelling enough for them to say it's not ethically right to not allow the group that's in the placebo to stay on placebo when we're seeing that significant reduction in heart attack and stroke at the 2.5-year mark. So again, it's just another factor that we know that inflammation is a key player in causing plaque to form in the artery. And we'll talk about some other things that we know are key players in that inflammation, whether we measure it or not. We know that these things drive inflammation in the artery wall. There are other tests that are done through special labs like Cleveland Heart Lab. So Cleveland Heart Clinic has a kind of it's an offset of Cleveland Heart Clinic, but it's a Cleveland Heart Lab, and all testing for Cleveland Heart Lab is done through Quest Lab. But they have other, we call it a fire panel. So that's looking at different arterial inflammation markers that will see if there's inflammation or heat in the artery wall. If we see heat or inflammation in the artery wall, the question is, what do you do about it? Well, you got to make sure that you're taking care of blood pressure, you're taking care of cholesterol, that you're taking care of any underlying blood sugar issues, the things that we know are going to cause inflammation in the artery wall. So that's a great question. Do you have anything else before I talk about blood sugar for a second?
No, actually, but let me give nothing in the chat, but let me just ask a quick question. Can somebody, does blood pressure correlate to high plaque? Could somebody have low blood pressure, but a lot of plaque, or would you expect to see a correlation there?
Yeah, so that's I actually wanted that's a great question.
Is that coming later? If it is, then we'll just
that's okay. So I'll go ahead and talk about it now, because that was good. I was going to talk about blood sugar, and then I was going to talk about blood pressure. So blood pressure is a really big deal. It definitely does affect that tennis court, that protective layer of the artery. So when the blood pressure is high, it starts to beat up on that tennis court, that protective layer. It makes holes and cracks in that protective layer of the artery and allows more plaque to get in the artery. So certainly, if you have high blood pressure, you are at a higher risk for cardiovascular disease. And certainly, too, blood pressure affects everything. It affects your eye health. It affects the health of your kidneys. And it also affects your arteries. One of the other things that I think people just, we don't talk about it enough, but we see it when we're down in the cath lab at the hospital, is when you have blood pressure that's elevated over a long period of time, instead of your heart arteries looking nice and straight, they look like Arby's curly fries. They have like these little curly cues in them. So when blood pressure is high over a long period of time, you have tortuous vessels. And when you have vessels that have these little curly cues in them, it becomes much more difficult for one of my expert physicians to be able to put in a balloon or a stent. So that's just another reason why blood pressure, and the goal of trying to keep that blood pressure 130/80 or less is really important, because it really does impact your arterial health, and actually even the shape of the artery can change over time with high blood pressure. And of course, too, high blood pressure unchecked over a long period of time will damage kidneys, but also damage heart muscle as well.
Okay, thank you.
Mm-hmm. And then blood sugar is a big deal, and I probably spend more time than anybody else talking about blood sugar in the office, but I know what a player it is in causing inflammation in the artery wall. If you have blood sugar issues, whether it's insulin resistance, pre-diabetes, and/or type 2 diabetes, we know that blood sugar really impacts the health of the artery wall. If you have a blood sugar problem, that starts to, again, beat up on that tennis court, that protective layer of the artery, making it much easier for bad cholesterol to get in. But blood sugar issues are like an irritant, almost like a sandpaper to the artery wall. It just kind of keeps inflammation in that artery wall. And therefore, when you have a blood sugar issue, it's almost like fertilizer for plaque. So we know if you've got heart disease, or you've got plaque in the arteries, and you've got an underlying blood sugar issue, really, we are even more strict about where we want your cholesterol to be. So for those patients who have blood sugar issues, plus they have plaque in the heart arteries, my goal for their LDL, that lousy or bad cholesterol, is under 55. I know it's got to be really low in order to prevent their risk of having plaque in the arteries. Also, too, when it comes to blood sugar, I would definitely recommend, if you are not having an A1C, an average of what your blood sugar is checked, which is kind of an average over 90 days. If you're not having that checked at least once a year, I would definitely recommend it. A fasting blood sugar just doesn't give you enough information to know your risk of whether or not you have a normal blood sugar, or whether you're pre-diabetic or type 2 diabetic. And if that A1C is less than 5.5%, then really you're A-okay. If that A1C is 5.6%, you're kind of on the cusp of prediabetes. And if you're at 5.7% to 6.4%, that is prediabetes. If you're at 6.5% or greater, that is type 2 diabetes. So I take blood sugar really seriously, because blood sugar affects everything. It affects your brain health, your eye health, your cardiovascular health, your kidney health, and even the feelings in your hands and your feet. And so I think blood sugar is a really big deal, and I want to take care of it as soon as I find an issue with it, versus saying, we'll watch the blood sugar for a while. Watching blood sugar just means it's going to get worse. So you want to make sure that you're addressing that appropriately. Now, the good news is you can change a lot about what's going on with your blood sugar just through lifestyle. It doesn't always mean medications. In fact, people who are kind of on the road to type 2 diabetes in that insulin resistant or pre-diabetic group, if they just change their eating habits and move more, then they can reduce their risk of becoming a type 2 diabetic by about 60%. That's better than some medicines. So I definitely know that there's a lot that you can do just day in and day out with your eating that can really aid in keeping the blood sugar down. And if the blood sugar is under better control, then your cardiovascular system is going to be much happier too. And that's why you see these newer drugs like the Wegovy, which is the weight loss medicine, that's the injectable medicine. What they've seen with that medicine is it actually reduces the risk of a heart attack by about 20%. So now it has a cardiovascular indication. That's because it takes care of the blood sugar. People they're losing weight on the medication. And so anytime you take care of the blood sugar and do that well, then your risk of a heart event is going down.
So because I know for sure I don't get my A1C checked once a year, but my blood sugar numbers on the regular metabolic panel always look fine. So I could even theoretically be pre-diabetic on an A1C panel, even though the traditional metabolic panel looks fine.
Yeah, so the fasting blood sugar that gets checked is just a one-time, just that moment in time. This is what your blood sugar is running at that moment in time. And that's great information, and we can learn a lot from that, but you just don't have that overview of what's my blood sugar really doing over a longer stretch of time period, to just learn a little bit more about your blood sugar story. The A1C, I think, is a key tool to that.
So it's able to actually test like what's happened over that long.
Yeah. So your red blood cells have a life of 90 days. So what they do with this test is they actually look at the red blood cell and they see how much glucose is in it, or blood sugar is in it. And based on how much blood sugar is in that red blood cell, they can determine what the average of the blood sugar has been running over that 90-day period. It's pretty neat. Yeah.
Yeah.
So the only thing that would skew that, just with thinking about you guys, is that if you have anemia, if there's something going on with your red blood cells that is abnormal, sometimes that can skew the result of an A1C. But if you're you've had kind of a stable red blood cell count for a while, then an A1C should be pretty darn accurate.
And is that fasting A1C?
You don't have to have it fasting.
Okay. All right.
And you got to think too, like with blood sugar issues like type 2 diabetes, it takes about 10 to 15 years to develop. So there's a lot of time that you're in kind of this pre-diabetic zone before you ever have a fasting blood sugar that's greater than 126 that would be considered type 2 diabetes. So my thought is find it early and then go after it early.
Yeah. No,
Yeah.
preventative. Okay, so we have a couple of questions in the chat.
Oh, yeah.
Okay, so first one is glucose levels important?
Oh, yes, for sure. Yeah.
All right. And can you reverse type 2 diabetes back to pre-diabetes or lower?
Yeah, that's a great question. So I certainly have patients who are able to do that. I think it depends on how much of your type 2 diabetes may be more related to your eating habits versus your genetics. So if you, certainly have had patients who have changed how they eat, how much they move, and have achieved weight loss. And those patients have moved themselves out of even a type 2 diabetic state, even down to a normal blood sugar state. So yes, you can certainly do that. I think it just depends on your risk factors and what are the drivers of the blood sugar issue to begin with. Certainly there are people who, their eating habits and their weight and their movement all play a huge role in what causes their blood sugar issue. And then some people, it's their genetics. They're already, they eat well, they exercise, their weight is fairly normal, and yet they have a blood sugar issue, and there's tons of diabetes in the family. So it all really just depends on what's the cause of the type 2 diabetes to begin with. But majority of us can do a lot better. A lot of us can control the blood sugar with how we eat on a day-to-day basis, and ultimately use the least amount of medicine possible to take care of the blood sugar.
We have a question also about low blood sugar and how that potentially is more dangerous.
So I will say this, low blood sugar, low blood sugar can certainly be a problem. A lot of times low blood sugar can be a red flag that there is an insulin resistant problem. So what happens in the insulin resistant state, either through your genetics or just your lifestyle, your muscle cells are not doing a good job of picking up insulin and using it to keep the blood sugar down. So the pancreas is very smart and will try to help out the body and produce extra insulin in order to kind of push that insulin into the muscle cells so we can get the blood sugar down. Sometimes the pancreas overshoots what is needed, and so you have these spells of hypoglycemia. And so it's very, I have a lot of patients who say, well, how can I have a blood sugar issue? Because, 15 years ago or 20 years ago, I was always having these spells of low blood sugar. So sometimes that can be an evidence of an insulin resistant issue. I would say in that case, for you, making sure that you are getting enough protein in the diet, lean protein, but at least 20 or 30 grams of some form of protein, at least 2 to 3 times a day in order to keep the blood sugar more stable. Because protein, when we're getting enough protein in the diet, we don't see the blood sugar going up and down like this. It stays more steady.
Okay, returning to glucose, question is, how do you lower glucose?
Yeah, so definitely it's kind of sticking with making sure that you're getting lean protein in the diet, lots of green vegetables, low glycemic fruits like berries, apples, citrus fruits, and then more daily and just moving more throughout the day. So all those things can actually really impact the blood sugar in very positive ways.
Okay, so Brittany, we're gonna get you next, but I'm kind of disappointed that nobody is asking if there's a type of wine if it's not the bad blood sugar. What's wrong with you all? Seriously, like everything I'm hearing is kind of grim.
Yes. Oh, they're Brittany asking. Thank you, Brittany, for coming through. What wine is good?
Thank you, Brittany.
What wine
I
lowers blood
appreciate
sugar?
that.
Yeah, so actually I have great news.
Exciting.
Wine is very low glycemic if used appropriately. So
My blood pressure is going up the longer we talk here.
It's summer. We all have kids at home. Let's be real here.
No, so I think, anytime I talk about lifestyle with people, it's always about little changes that you can make that are sustainable over a long period of time that will help your blood sugar and your cholesterol, and even your blood pressure too. So wine, and unfortunately, the serving size of wine is only about 5 ounces, but a glass of wine is a low glycemic, has a low glycemic index, which means it does not impact the blood sugar that much.
Oh, really?
So that is a-okay.
But it's like,
It's usually like the frozen fruity drinks, the things that are in beer. Those are things that are really high in carbohydrates. And so I would say, definitely having a glass of wine is with dinner a-okay. But it tends to be the mixed drinks that have a lot of excess added sugar. It has like it has a the simple sugar, syrup in it. Those are the things that tend to cause blood sugar to be elevated.
well, and it is hard to keep the weight down.
Yeah.
Yes, for sure.
Okay, do you want to do Brittany?
Sure. Yeah.
Thank you, Brittany. Then.
Another question about having an echo prior to chemo. A lot of us, I had an EKG. I don't know if they're the same thing, but what would that have picked up on any inflammation? And then should we be getting any kind of post chemo rechecks? Because a lot of times they test us before we start AC because of the effect on the heart.
Yeah. So that's a great question. So an EKG is basically a picture of what's going on with your heart rhythm and rate at that particular moment in time. And EKG, when you're having the EKG done. And so EKGs are a great screening tool, but they certainly do not tell us everything. And they are certainly something that we use in cardiology to know if you're having abnormal heart rhythm at that moment. We can see sometimes waveform changes on the EKG that could indicate that there's something going on structurally or circulation wise with the heart. But it just can't tell us everything. And you can certainly have an EKG that looks really nice, but still have a lot of stuff going on with the heart. So EKGs are great, but they're very limited as to what they can do. An echocardiogram is an ultrasound of the heart. An ultrasound of the heart is looking at the structure of the heart. So we're looking at how well the heart muscle squeezes and pumps blood to the rest of the body. And then we're also looking at the heart valves and making sure that the chambers of the heart are of normal size. So that is kind of the best test to do prior to having, or a really good test for you to have done prior to having chemotherapy. There are, I would say, depending upon what chemotherapy that you're on, we know that there are some that are more cardiotoxic than others. And so your oncologist should have a good idea of what, if they're giving you something that's cardiotoxic, they have a protocol that they have to follow as far as how often you need to have an echocardiogram during your treatment phase. I would say if you have finished your treatment phase, I would recommend just having, if you're in remission, just having a kind of a screening echocardiogram after all the chemo, just to make sure everything's a-okay and kind of know where your new baseline is after everything that you've been through is a good idea. But that's really looking only at the structure of the heart. And there are very specific types of echocardiograms that we do to look for cardiotoxicity from chemotherapy agents. Those are echocardiograms that with what's called longitudinal strain. So it's an echocardiogram with GLS. And so that's a very specific kind of measurement that we take to look for evidence of impact of chemotherapy on the heart and the heart muscle, on the myocardium. Okay, so that's an echocardiogram. Now, if we want to talk about testing or looking at the heart arteries to see if there's plaque in the heart arteries, then we're talking about other types of imaging. And the type of imaging that I use the most for just screening is a calcium score, and that's a CAT scan of the heart arteries without contrast. So you're literally on the table for about 5 minutes. And what that does is let me see if there's evidence of any plaque in the heart artery. If your calcium score is 0, that means no plaque in the heart arteries. Your risk of having a heart event over the next 5 years is very low if you have a calcium score of 0. If your calcium score is elevated, and the higher that score is, the higher the risk of significant plaque burden. So if I know that somebody's had an elevated calcium score, I would want them to do some sort of stress test on the other side of that to make sure I don't see evidence of obstructive plaque in the heart artery. Because again, the calcium score is limited. It can tell me if there's plaque present. It can give me an idea of how much plaque is present, but it can't tell me anything about flow through that heart artery. A stress test is the best way to do that. And for women, having just a plain exercise treadmill test is not enough. You either need to have a stress echocardiogram, which is where they do an ultrasound and a stress test kind of all at the same time, or you either have one of the nuclear scans, or you can have, if you have, particularly with women who have a large breast, if you can do a cardiac MRI stress test, then that kind of takes away, we can basically get a better idea of what's going on with the heart without any impact and breast artifact on a stress test, because that can be an issue for women. And then also we do tests that are called coronary CTAs. That is a CAT scan of the heart arteries with contrast. And that is, we're basically watching that contrast go through the heart arteries, see if there's plaque in the heart arteries, and it can see flow through the heart arteries. That's like the next step above a stress test. And the step above that would be the gold standard test, which is the heart catheterization test. And that's where if we need to put a balloon or a stent in, we do that in the hospital setting. A calcium score, the screening test, is somewhere between $50 and $75 without insurance.
I had one and it was covered by my insurance.
Oh, was it?
Awesome. Yay.
How would the stress test, for those of us that have implants, the one you were talking about where they couldn't see through the breast tissue or whatever, how would that affect it at all, the implants?
Yeah. So I think if you have implants, probably the best stress test to do is the cardiac MRI stress test. So that's where you're in the MRI machine. And that's actually a really nice test, because and we can talk about if you have claustrophobia and can't do that, but that type of test, what it will do is it looks at the heart muscle. It actually looks to see if, and it gives a very detailed look at the heart muscle. It also looks at the heart valves, and then you're also looking at doing the stress test. So you're looking for evidence of a perfusion defect or ischemia. That would mean that there's a lack of blood flow to a certain area of the heart, and that means that there could be a potential blockage. And then we need to do more. We need to do the gold standard test, the heart catheterization, if that came back abnormal.
And you said 5 years on the calcium.
Yeah, so if you had a calcium score of 0, yay, that's a good thing. I would definitely recommend doing one again in 5 years.
Okay. All right, let's see, we're at 12:57, so we've got a couple last questions in the chat, and then we want to be respectful of your time. I know you have a very busy day. So is it better to, going back to wine, thank you. Is it better to have protein with the wine and keep the blood sugar level, or any other sugar type food? So any ways to mitigate the impact of the sugar from the wine on your—
Yes, cheese, wine and cheese.
Wine and cheese?
Anytime that we, anytime that you're having something that so like wine has, again, wine is fairly low glycemic, but having it with your meal versus just having it on an empty stomach, and making sure that your meal has some sort of protein in it, that's just going to not allow the blood sugar to spike and then come back down. It's going to keep the blood sugar more stable. That's always the key. Just like with fruit is, it's a carbohydrate, carbohydrates equal sugar. If you pair your fruit with Greek yogurt, or if you pair it with a handful of almonds, then that's just going to make sure that the blood sugar doesn't do this and then come back down. It's going to keep the blood sugar more stable.
Interesting.
Yeah.
I read about food combining. Does taking an aromatase, and I always have trouble with that,
inhibitor,
increase plaque in arteries, and is it a risk factor?
It certainly can be a risk factor. We know that these drugs can also raise your cholesterol too. I don't see a huge bump in cholesterol with these drugs, but it can, if you're kind of if I have some patients who have been watching for a long period of time, I can see, a 10-point-ish increase of bad cholesterol in these drugs for sure. So, we know that, it's always with everything, it's risk versus benefit, right? So certainly if I have somebody that I'm watching their cholesterol go up a little bit, I can always kind of maneuver around that, adjusting medications in order to bring the blood sugar back down. But yeah, certainly these drugs can increase risk.
And theoretically, should it go back down once we're no longer on the AIs?
Theoretically, yeah. But you also you have to think too, particularly for women, we are really, our estrogen protects us for a while and keeps our HDL high and our LDL low until we start to hit that perimenopausal state. And then as we start to lose estrogen stores, that's when we tend to see higher LDL to begin with. And that's when we start to see our risk of cardiovascular disease become much more equal to what our male counterparts are. And certainly we're seeing that I think at a higher rate and earlier in life, because we're not as healthy as we once were. But certainly, so, you've got to think if you guys are on these medications for 5 years, then there's other things that are going to be going on. So it would be interesting to see kind of where the cholesterol is, but it may be too that we're seeing some signs of the cholesterol going up just because of other things going on as well. Okay. Whether it's blood sugar related or hormone related or age related changes.
All the things.
You're not
all the things.
Okay, well, this has been incredibly informative. Thank you so much. The final question, I think Dawn wanted to know the name of the calcium test. I just wrote calcium score. I'm not sure if it's called something else. Yeah,
it's called a CT calcium score. And we do those in the Nashville area. We do this at Premier Radiology, and then we also do them here at Williamson Medical Center. And at Williamson Medical, we use our outpatient facility, which is bone. So they're a really nice CAT scan machine, and nice building within our nice place to get that done is that bone and joint. The orthopedic group, they have all Williamson's imaging for that is down in that bone and joint suite that's right next to Williamson Health. So you can get it done there for about $75, I think, there. But I would definitely recommend having that because a stress test is only going to pick up an area of plaque if it's greater than 60%. So you can pass a stress test and still have plaque in the arteries. So a lot of times I pair doing a stress test and a calcium score along with the lab work, because I want to know what's going on from biology with your labs, and then also what's going on in the anatomy. And that's going to give me my best chance of making sure that we protect your heart arteries both now and for the long haul.
But is that something we need an order for, or we can just call?
No, you need an order for it. Or your primary care can do that, or you can come see me and I'll do it.
Okay, okay.
Yeah.
Thank you so much. This has been
This is
amazing.
amazing.
You
Oh,
are,
thank you guys so much for having me. I wore my pink for you, so
I appreciate it.
I love the fact that you guys have this community together. Just an amazing thing that you guys do.
Yeah, thank
Feel
you.
the same way about you. Thank you very much. Really appreciate your time. Hope everybody has a great week.
Really informative.
We do
Okay.
not have banter in July.
Yes.
The banter
We're
ladies
on
are taking the
our
month off.
vacation.
Oh,
And
yay.
we
We have
will
kids
see
off.
you back in August. Stay in touch
tuned.
on our socials and our website to find out the date of the August banter. But
Yeah.
we look forward to seeing you guys next time. Hope you have a wonderful
Yeah,
summer.
Enjoy your summer.
Thank you,
Bye.
Amy.
All right,
Thank you,
thanks.
Amy.
Bye, everybody.
Bye.